Thanks, Kristen. Hi, everyone. Thanks for joining the discussion today on encouraging high-quality medical provider participation in work comp. For those of you that don't know who I am, my name is Carlos Luna. I have the pleasure of working for Risico Total Managed Care. It's a Fresno-based URAC-accredited division of Risico, Inc. Risico is a multifaceted organization that provides claims management services and insurance products, in addition to managed care services to thousands of customers throughout the state of California. I'm extremely excited and humbled to be joined today by who I consider to be some of WorkComp's brightest minds. My colleague Sharon Mather is with us today. She's Risico's Vice President of Nursing. Dr. Stephen Feinberg, a very popular and charismatic, I should say, physiatrist and pain medicine specialist, widely known in WorkComp for his work as a panel chair for ACOM's 2017 Chronic Pain Guidelines Update, as well as the numerous presentations that he's conducted in conjunction with the California Division of Workers' Comp. I'm also joined today by Dr. Stephen Wiesner, who is the Northern California Kaiser Permanente on-the-job Medical Director of Workers' Compensation Services and Healthcare Organization. Please be advised that the information shared today is for educational purposes only and should not be considered legal advice. Sharon, with all the complexities faced by stakeholders in the work comp care and claim continuum, there's an optimal way to make it work to benefit the employee and the employer.
Thanks, Carlos. Yes, I'm going to actually kick off the webinar with a story that I think is very important for everybody to hear. Our industry hears a lot of negative stories about utilization review. I'm going to share a story of an actual case where a UR nurse performed specific activities that facilitated authorization of an injured employee's treatment plan. A 26-year-old health aide sustained significant facial trauma to her eye, mouth, and teeth after being assaulted at work. I'm going to call her Jane. That's not her real name, but I think it's important for everybody to remember that behind every RFA is a real person. Jane had several treating providers due to the severity and complexity of her injuries. She required multiple procedures, including tooth extractions, implants, removal of implants, and various other procedures over the course of a 14-month period. During this time frame, Jane developed complications including abscess formation, bite, and TMJ problems. Jane also had periods of severe mouth pain. A treatment request was received from an oral maxillofacial surgeon's office. The medical report attached to the request for authorization was void of any pertinent clinical information and the medical rationale to substantiate the requested treatment. The nurse performed multiple activities in an attempt to obtain necessary information. She contacted the examiner and asked for all available reports. She also called and spoke with the staff at the requesting provider's office, advising them that the reports that were submitted for review were missing any pertinent information and the necessary clinical information to substantiate the requested procedure. During the nurse's conversation with the office staff, it was identified that there was a more recent office visit. However, the report from that office visit was not yet available. It was in transcription. The office staff confirmed that the recent office visit and pending report did provide information related to the requested procedure. The nurse then provided the education regarding what was needed to facilitate the review process. She asked for the pending report and the additional information to be expedited, which would allow her to perform the utilization review process. The requested information was still not received by day 5, which is a regulatory time frame. Prompting the UR nurse to follow up again with the provider's office, she sent an official written notice to the providers requesting the necessary documentation and outlined exactly when it was due. These actions extended the UR time frame to allow additional time for the provider's office to submit the necessary reports and documentation related to the treatment request. She made every attempt to prevent a denial and/or delay of treatment. She was able to secure the necessary clinical information within the allotted time frame. Immediately when she received the information, she reviewed the request and identified it was consistent with medical evidence-based guidelines. The nurse certified the treatment. This scenario demonstrates a collaborative process that was implemented by the UR nurse to work with the provider to facilitate authorization of appropriate treatment. Her specific activities prevented a denial and unnecessary delays in the injured employee's treatment plan, as well as it contributed to the employee's progression to maximal functional restoration. So why go through all of these activities that the nurse went through in the story I just told? Let's look at some lasting effects and what happens when an injured employee is provided timely, high quality, and appropriate treatment. The injured employee is positioned to achieve optimal functional outcomes, returning to productivity at home and at work. We know physical and mental deconditioning takes place the longer someone remains off work. We also know certain mindset changes take place. Getting them back to their daily activities and life in general is very important. There are reduced indemnity and disability costs for the employer, and there's a decrease in lost time and productivity when the employee returns to work. There's reduced litigation and timely resolution of the claim, which is optimal for the claims folks. Providing timely, high-quality, evidence-based medical treatment sets the stage for a win-win for all.
Sharon, thanks so much for that information. You know, high-quality, timely medical treatment really can have positive, lasting effects, not only from a health standpoint, certainly from a cost standpoint as well. In fact, NCCI states that medical services account for approximately 60% of all annual workers' compensation costs in the US. In California, medical services accounted for 56% of total loss payments. You know, with medical services exceeding half of total loss payments, I think it's important for stakeholders in the system to realize that high-quality providers can play a crucial role in improved cost outcomes and health outcomes for injured workers. One thing that I think we really need to acknowledge and be aware of is the fact that there is actually a lack of high-quality providers willing to treat industrial injuries, not just in California. It's not a story that's respective to any one jurisdiction. In fact, it's been reported by numerous states throughout the country. The Federal Health Resources and Services Administration found that at least 55 million Americans live in areas with a supply of primary care doctors that is actually inadequate. The issue of available high-quality medical providers is probably further compounded in workers' comp due to the inherent characteristics of the system. Now, I want to ask a question of our two physician panelists today, Dr. Feinberg, Dr. Wiesner. In your opinion, why is workers' comp the path less traveled by high-quality medical providers?
So, Carlos, thank you very much. It's Steve Wiesner. So there are inherent obstacles that the system can create, and Dr. Feinberg will talk about how to overcome some of those obstacles. But when you have a healthcare provider who is focusing more on their own financial interest rather than that of the injured worker, the employer, the other stakeholders, those are the folks that we probably are not going to see the highest quality and the most positive functional outcomes. And speaking of function, when we also identify clinicians that are focused on the biomedical approach to clinical care, rather than really looking at the biopsychosocial issues that can oftentimes complicate the recovery, those clinicians are going to create some challenges within the work comp arena. And this is a service line, or this is a type of benefit system that requires engagement amongst all the stakeholders, so that we do have a clinician who is not willing to be available, who is not effective in their communication, in their timely responses to claims examiners, to employers, to their own patients' requests for additional information and clarification. That's going to create some challenges for that patient's recovery. And lastly, if we don't respect all of the stakeholders that are relevant to helping the injured worker safely and timely return to their highest level of functioning, that is going to delay and frustrate many, many people within this work comp benefit process.
So this is Dr. Steve Feinberg. You know, unlike the non-ideal medical provider that Dr. Wiesner just talked about, the ideal provider focuses on helping the injured worker heal from the injury, appropriately manage discomfort without turning to drugs, and really encouraging a return to everyday life activities, and that means work as well. Rather than focusing solely on the pathology, the focus involves that whole person biopsychosocial approach Dr. Wiesner mentioned. The ideal medical provider also understands the nuances and requirements of the particular workers' compensation system and works within that system to provide evidence-based medical care. Now, this is a summary slide, and I can only emphasize that it really becomes a win-win situation when all of us, attorneys, claims examiners, the patient, the doctors, all work collaboratively to serve in assisting the injured worker to manage their pain, increase function, and return to work. In this scenario, sincerely, everyone benefits. I can tell you from my personal experience after many years of practicing medicine, this functional restoration biopsychosocial approach is not only supported by all evidence-based guidelines, but clinically is highly effective. Dr. Wiesner, what's your experience in terms of Kaiser on the job in the early front end of treatment?
So I realize, and let me acknowledge that the practice that I'm in may be somewhat different from the practice of people that are participating on this call and this training. I'm very fortunate to work within an integrative medical model and work in a system that focuses solely on giving the highest quality of care to someone who may be injured at work, but just as importantly, working with employers to hopefully prevent injuries from ever occurring in the beginning. I also have a full team of support members that are always focused on what is best for that injured worker, for that patient, and working collaboratively within our team, making sure that we're available to communicate effectively, again, with the other stakeholders we understand as being absolutely critical to getting the best care in a timely manner for that injured worker. Because any delay that is created within our clinic ultimately is going to have a negative impact on the patient, leading to greater cost and frustration for all of the stakeholders in that department.
Okay, I would actually like to ask Dr. Wiesner and Dr. Feinberg to provide their input on what they feel detracts high-quality medical providers, those ideal providers, the ones we all want, from treating injured employees. Dr. Wiesner, why don't you start?
So I think it's similar to what Steve and I have already mentioned. If we don't provide the right incentives and we don't encourage those physicians who at least have an interest in practicing in the work comp arena, we're not going to get the best clinicians to be in that environment. So making sure that we are supporting the time that is needed for the clinician to explain to the patient what the work comp benefit system actually means, to set clear and appropriate goal-oriented expectations, even beginning those expectation discussions at the first visit, and then making sure that the ultimate goal is explained to the patient, and that is giving you the highest quality of care that is evidence-based, which is quite different than giving the patient anything and everything that they want, doing that in a timely basis, and following the jurisdictional medical legal issues that we have to work under within the work comp arena can set the stage for a very positive outcome.
You know, let me take a step back and frankly talk about some of the negatives that I literally deal with every day as a treating physician. My colleagues and I are dealing with higher patient volumes, sometimes demanded by the organizations we work for. We're not really given enough time to deal with complex cases. And frankly, the work comp system is different in the sense that there's a tremendous amount of paperwork. The simple task of filling out an RFA is not a simple thing in terms of time. My perception is that the system we work in gets bogged down, and frankly, I find it shocking how few physicians follow the MTUS, how few even understand it, and how often, at least what I'm seeing other doctors' reports, the treatment plans are inadequate, excessive, or just plain ineffective. And frankly, physician incentives are imbalanced or out of balance. You know, we get paid more as physicians to stick needles in people and do tests and procedures than to talk to them and help them get on with their life. I find electronic medical records extremely problematic, and frankly, from my point of view, they're destroying the practice of medicine in terms of the stuff I'm seeing. It's difficult to get doctors to change their behavior, but we need to remember that doctors are angry and frustrated with having to play this mother may I game in terms of just doing what they feel they need to do. And that's just the way it is.
The barriers and the challenges that both Dr. Feinberg and Dr. Wiesner identify are truly multifaceted and really, they really deserve to be expanded upon in their own respective webinars. And hopefully someone in the audience listening today might be inspired to pick up the baton here and take it to the next step. But for the purposes of our talk today, why don't we group these barriers into two general themes, rules and relationships, and then let's dive into each a little bit deeper. So why don't we talk a little bit about rules? We've heard, I know I've heard DWC Director George Perisotto on multiple occasions cite that the system is just too complex. From a regulatory standpoint, that certainly couldn't be more accurate. In fact, a survey that was conducted several years ago by the California Medical Association cited physician members stating that there are significant challenges with the work comp reforms that stemmed from the enactment of SB 863. When you take a look at the survey a little bit closer, you'll find that 67% of respondents reported difficulty obtaining authorization for patient care, and that certainly resonates with what Dr. Feinberg was just talking about. More than half cited inappropriate denials of medically necessary tests and procedures. I'll continue on by saying that 67% of the respondents also believed that the IMR process was unsuccessful in ensuring the approval of appropriate medical care. But I'll say this somewhat tongue-in-cheek. So Dr. Feinberg, Dr. Wiesner, don't pinch me here. But a quarter of the physicians that actually took the survey didn't even know that IMR existed. So I think that there's ample opportunity on both sides of the fences. Now, the sentiment then was that the process was in fact difficult, but has become hideous following the enactment of 863. And I can certainly say that some physicians still feel that way today. Unfortunately for all of us involved in the system, the complexities that come with rules, with regs, or overly regulated processes, I should say, really have the potential to take a medical issue and turn it into a legal dispute. Wouldn't you agree with that, Dr. Feinberg?
I would. Let me give you an example that comes to mind. There are things that are legal. For instance, whether or not the work injury was legitimate, whether a particular body part was involved. Injured workers sometimes become very entitled. They have beliefs about what was injured and what wasn't. But on the other hand, I actually do see more than a few cases where the doctor in the original health clinic didn't list a certain body part, yet the physical therapist in that same clinic listed it, and yet the claim was denied. So while it's legitimate to get more information in terms of body parts, when you do that and put something on hold, you create a system where the injured worker becomes angry, defensive, upset. They may not be able to get medical care, particularly if they don't have non-industrial insurance, or their non-industrial insurance may say, well, it's work-related, so we're not going to cover it. And so what we often see is the claim going south when this happens.
If I could also comment, just to follow up on what Carlos has unfortunately shared with us and highlights why it is difficult to encourage high-quality providers to work in this system, is it is critical for the clinician to have the foundational knowledge and the importance of understanding that evidence-based medicine is what is expected. And if that is not accepted at the clinical level, that is going to be a challenged physician who will create challenges for everybody else within that benefit system. So my point is, there's an onus on the physician to make sure that they do have the support, that they're getting the education and the training to understand the importance of evidence-based approaches, and specifically understanding the jurisdictional medical legal requirements within the system. And Carlos will talk about some of the regulatory importance as well.
Okay, so the prior slide is a reflection of physician input from a California Medical Association survey completed in December 2014. Let's look at some of the key changes in the industry and the intended purposes of those changes. California implemented an independent medical review dispute process for utilization review, denials, and modifications in January of 2013. That was actually the result of Senate Bill 863 that we just talked about. Prior to this process, disputes over medical treatment requests were settled by workers' compensation administrative law judges. Now the IMR physician, a physician, not a judge, has a responsibility of determining whether or not a disputed medical service request meets evidence-based guidelines and to preclude unproven, unnecessary, and potentially harmful treatment. IMR decision timeframes have gone from 162 days in Q2 of 2014 to between 31 to 34 days for the first half of 2018. Those numbers are from CWCI's September 2018 executive summary for IMR decisions from January 2014 to June 2018. Assembly Bill signed by the governor, Assembly Bill 1124, which was signed by the governor in 2015, required the administrative director to establish a California drug formulary for medications prescribed in the work comp system. This went live January 2018. We know that many states across the United States have also adopted drug formularies. Senate Bill 1160 made significant changes to the UR-IMR processes in California's work comp system. Intended changes: reduce delays in the provision of medical care, expedite appropriate care, increase communications between treating physicians and UR reviewers, and improve the overall quality of UR services in the work comp industry. A few highlights are, effective 1/1/2018, there is limited prospective UR for most treatment in the first 30 days from the date of injury. There are some conditions and exceptions to this. Exempt drugs on the formulary list may be prescribed without seeking authorization through prospective UR, if in accordance with California's MTUS guidelines. Moving on to the next slide, I think it's important that we look at how can friction created by an overly complex system be avoided. Let's have each panelist provide input from the vantage point of the various stakeholders outlined in this slide. Carlos, can you start with the claims administrator and employer's perspective?
Happy to, Sharon. Before I dive in here, let me just take this opportunity to welcome any participants on this webinar from the states of Florida, New York, the Midwest. I know that we have numerous individuals that signed up from throughout the countries, or throughout the different states in the country. I do want to say that the best practices that we're about to mention definitely would apply in each jurisdiction. For example, let me dive in as a claims administrator and an employer standpoint. In my opinion, employee advocacy really is the key here. For example, claims administrators really should be passionate. Let me emphasize that. They should be passionate about driving treatment plans forward. You know, if something doesn't make sense, they should exhaust all resources. Make sure that things don't get stuck, as Dr. Feinberg often says. Show the employee and the physician that you're on the same path, that you care about the employee's recovery. Employers, you know, you really should strive to have working relationships with providers in your network. Help them understand your operation. Talk to them about your philosophy on return to work and stay at work.
I'll pick up talking about attorneys. I'm going to assume there are no applicant attorneys on this conference, but
Whoops.
there may be. But, you know, I work with a lot of applicant attorneys, and the great majority of them are just trying to do what they think is best for their clients. But some do pursue discovery and raise issues that only seem to target increase the overall case value. Whether or not increased recovery truly benefits their injured worker is another matter. And so the applicant attorney is not necessarily the enemy, but rather someone that I think if we work with them better, we'll get better outcomes for injured workers. I want to talk to you about defense attorneys. A quality defense attorney really acts as a bridge between the applicant attorney and the payer employer, but at times the involvement of defense counsel could also lengthen and further prolong the time to settlement. in terms of avoiding friction, when the attorneys are actually working together, and as a treating doctor, I see this happen in some cases where they'll both talk to me and say, let's work together to get this injured worker back to work. And I got to tell you something, when this happens, the outcomes are usually pretty good.
Having the right nurses and clinical teams and programs in place is imperative. Nurses need to function as a clinical resource and liaison to facilitate the authorization process of appropriate evidence-based treatment. Nurses should engage in proactive activities with providers to prevent treatment plan delays or denials, such as the nurse did in the story at the beginning of the webinar. Providing pertinent education and resources regarding regulatory processes and state-approved evidence-based guidelines are oftentimes very helpful to the provider. Helping them understand the rules and educating them so that they are successful at utilizing and navigating the guidelines. That will facilitate authorization of appropriate treatment plans. The nurse should collaborate with the claims professional and discuss how a diagnosis or particular treatment request may be appropriate and related to the claim, where applicable, so that the claims professional does not defer UR of necessary treatment. A good example is how cognitive behavior therapy is appropriate for a patient with chronic pain, even if they do not have an accepted psych claim. This therapy is consistent and supported by guidelines. Authorizing this treatment does not mean you are accepting a psych diagnosis on your claim. However, deferring UR for the cognitive behavioral therapy for a patient with chronic pain treatment will cause friction and delays in necessary treatment. It can and will likely prolong your claim. Teaching someone positive coping mechanisms and learning how to deal with their pain can be extremely beneficial. Nurse case managers should function as a liaison to all, provide critical education to the injured employee, ensuring that that injured employee understands his or her injury, the treatment plan, expectations, and most importantly, empower the employee to advocate for himself. This is critical. Explaining the UR process is vital to the injured worker. It is a maze to them and they don't understand it. The employee needs to understand why something has been denied and his options, including a second opinion and the IMR process. The nurse case manager needs to work in partnership with physicians, facilitating timely and effective treatment plans. If a denial is issued, we all need to kind of sit back and think about what happens. Basically, everything stops. Someone needs to follow up with the physician to discuss next steps. Dr. Wiesner?
So just to highlight all the excellent comments that my colleagues have made today, especially what Sharon shared, and that is, to be an effective clinician in this system, you have to be willing to communicate. You have to be open to that engagement with the other stakeholders, as I've mentioned previously, especially the claims examiners. And as Dr. Feinberg mentioned, some of the best outcomes come from an understanding and a discussion between the employer and the clinician. It allows the clinician to best understand what the real and true job duties are of that patient, educating the patient that activity is healthy and good for healing so long as it's safe activity, and providing timely medical reports that are based on appropriate utilization documentation, and that the patient is understanding the why of the system, as Sharon mentioned, and the importance of safe return to general life activity being the focus of the actual care provision plan.
You know, before I go to the next slide, I want to apologize to all my friends on Capitol Hill for this. Don't be terribly offended, but at the end of the day, you just cannot legislate good behavior, ultimately is what we're saying. It's really cultivated by the interaction that we have with one another, with other stakeholders involved in the care and claim continuum. In fact, I'd say that really, relationships are key.
Yes, I will absolutely second that. Relationships are extremely important, and looking at some of the reasons for the breakdown of relationships in our system is also important. Communication is oftentimes overlooked, but yet it's most critical to the equation. Ineffective, insufficient communications cause a breakdown of relationships throughout our industry. WOMA published a paper in 2014 that demonstrated the need for system-wide improvement related to communications and amongst all stakeholders. As we have discussed, Senate Bill 1160 made substantial changes to the UR-IMR process in the California's workers' compensation system. George Parasoto and the DWC announced this month that California's evidence-based treatment guidelines, the MTUS, are now available online to treating providers and without the providers having to purchase a license to use them. At the 26th annual DWC conference this month, he stated, in quotes, "I've heard constantly about the fact that frontline physicians were not familiar with our guidelines. I can actually say that I can second that. Many treating physicians will say that they have never seen the MTUS treating guidelines and/or formulary list, or they simply don't know how to use them."
Sharon, I'll take that a step further. You know, I've interacted with numerous providers from throughout the country, and it still fascinates me, and maybe Dr. Feinberg, Dr. Wiesner, you can weigh in here, but it still fascinates me how many providers just are not really that well knowledgeable on evidence-based medicine and the use of it at the point of care.
Well, I think that's true. You know, I do a lot of teaching, and I'm kind of amazed. I did a webinar recently about how to use the guidelines, and you know, I had one doctor come up to me a week or two later telling me that just following the steps, which are fairly simple, it really changed his practice life. He's getting fewer denials, and so I think we all just have to not give up and keep working with our clinicians. It's hard to change physician behavior in a busy practice. Some doctors just feel they know what's best for the injured worker. But frankly, if you're not going to follow the guidelines, you're doing more harm than good. And the other side of this is switching to the ACOM guidelines actually is very beneficial when it comes to chronic pain, which is the area I am in. There's lots of stuff the guidelines are positive about, and you just basically in your reports as a physician note that, for instance, something as simple as psychological care is supported by the guidelines. And as a physician, if I were to put that down and say this is guideline supported, I should get it authorized.
So, and I would completely agree with Dr. Feinberg. It is a commitment, and a commitment is time to learn what the guidelines are. There are various tools, and I really appreciate the State of California Department of Workers' Compensation providing all clinicians in California with the ACOM guidelines. It eliminates one excuse for a treating physician not to know at least what the guidelines are, but that does take time. That takes a commitment to learning what the system requires. My goal would be that if the clinician can prove they are consistently using the guidelines, and when they need to go outside of the ACOM guidelines, they're using other evidence-based support, such as specialty societies, other treatment guidelines that may not be specific to the work comp arena, that those physicians should not have to go through the UR system. They should be given the trust and the support to say, you've proven to us that you understand evidence-based medicine, you've proven to us positive outcomes, you understand the biopsychosocial approach. Why would we waste our money in putting your request through UR? That would ultimately be my goal.
Dr. Feinberg, I think you should mention to everybody, if there are physicians on the call, that your webinar was recorded. It's still available for them to watch, correct?
It is, and you're always welcome to email me, and I'll give you that link.
Our UR supervisor and myself actually showed that webinar to 7 or so occupational medical doctors, and we had nothing but great feedback, and they felt that it was a very good and simple way to learn to navigate the system, which before, when they tried it on their own, they weren't so successful at it.
Sharon, WorkCom Central and I, as well as the Reed Group, are putting on another webinar about how to use the guidelines. I think it's May 17th, and I would encourage everyone to sign on for that.
Great. Okay, so now we're going to move on to relationships and denials, which is a very hot topic in our industry, and I'm sure throughout the nation. Let's kind of look at what happens when there is a denial. So when an injured worker is told by his physician that a particular treatment is needed for his recovery, and then it's denied, he feels like the insurance company does not care about him and that the denial is financially based. I know we've all heard that. When a provider receives a denial, he becomes frustrated. Oftentimes, this can cause stagnation of the treatment plan and return to work, and then everybody's frustrated. Inappropriate denials create frustration and can cause significant delays in an employee's treatment plan, as well as delays in their progress to achieve maximum functional improvement. But that's not to say all treatment should be authorized. Sometimes treatments and procedures can make one worse. They can cause serious problems, risks, and drive disability. More does not mean better. Needless surgeries or inappropriate prescribing of narcotics is detrimental to one's health. Clinical decision-making and medical care should be medically evidence-based.
Let me chime in here on something that literally happened yesterday to me. We had seen an injured worker in my practice who had injured the left shoulder and was having some compensable, what I believe was compensable right shoulder discomfort. Very straightforward patient, no exaggeration of symptoms. So we put an RA for physical therapy for the shoulders, and we got a denial back saying that the right shoulder was not the injured body part, and therefore there was no physical therapy authorized, even for the allowed left shoulder. And while I understand that, I have a frustrated injured worker who I had to spend extra time with calming them down, and we had to put a new RFA in and explain that, well, this was a compensable consequence. We can't just treat one shoulder and not the other. It wasn't efficient. So those are the kind of things that we see in our practice that are so frustrating to us.
So team, I've got a question for you. What are some practical ways to improve communication? I mean, it certainly sounds, Dr. Feinberg, like the situation that you had, had the various stakeholders gotten around the table, talked through it. It certainly is common sense, right? It makes sense what you're recommending. And sometimes that communication path just isn't as visible as we need it to be. But what are some practical ways to improve communication, education in an effort to reduce denials? And let's take the same approach as last time. Let's go around the table. I'll start with the claims administrator and with the employer. I'll say to my friends in the audience that are claims administrators, you really should be diligent about communication. You should treat it as your primary job. Be a good communicator. Communication with physicians, for example, make sure that you're taking calls when they're calling you to clarify something. Make sure that you're returning calls. Certainly reach out to physicians if something is missing or unclear with their request. Don't make assumptions or automatically deny. Dig a little bit deeper. Now, communication with employees is particularly important, as Sharon was talking about. Make sure that the injured employee receives copies of the treatment authorization so that they're aware of the certifications, not just the denials or modifications. Help them see some good news from you as opposed to just the bad stuff. In my opinion, this will certainly bridge any communication gap. Now, from an employer standpoint, earlier I stated, make sure that physicians in your network understand your philosophy on return to work and stay at work programs. Let me take a step back here, and this again is a little, I like to play on the line, as they say, so don't be too offended with me by saying this. And Drs. Wiesner and Dr. Feinberg, please chime in and let us know your experience on this. But I would say to employers, make sure that you have or offer a return to work, stay at work program. I'm flabbergasted by how many employers still do not offer modified duty. I've heard, many of you have heard my good friend Bill Zachary talk about the benefits of return to work, of reducing overall disability duration by getting these injured workers back to work at an optimal time frame at an appropriate level of modified duty. I think it plays a key role in productivity. Doctors, what do you see in terms of your practice? Are employers friendly to the concept of modified duty? What are you seeing out there in the real world?
Well, it's quite varied, and it really depends on the employer. The small employer is just trying to stay alive these days. Margins can be very low, but still it pays off to call the injured worker when they're injured and say, how you doing? A card in the mail, a phone call. I wanted to respond to your what you talked about, the claims examiners, because I love examples. I got a call from a claims examiner saying, Dr. Feinberg, I know you're real busy, but I'm concerned about this injured worker. Is there any way you can get them in? Because I'm going to authorize whatever you say we need to do to get them back to work and healthy again. You know, that kind of extra effort just is so phenomenal, and it's hard to fail when you have people working together. You know, part of my part is talking about the attorneys. You know, in the best of all possible worlds, and it's certainly not the one we live in, as I mentioned in a previous slide, the attorneys would be working together, both defense and applicant, but also the claims examiner and the applicant attorney and the physician, to really, you know, help the injured worker maximize function, feel better about themselves, return to their everyday life activities, get back to work. The employer is a big part of this. People do better when they're working. The statistics are very clear about this. The longer you're out of work, the less likely you are to go back. You know, when the focus is on being a decent human being and treating the injured worker like someone you care about, everyone benefits. The system benefits, the injured worker benefits. And frankly, another little story here. I had a defense attorney tell me incredulously, by the way, you know, you were the doctor on this case, and the injured worker hugged me on the day of trial because we had authorized something you recommended. And the attorney said, no one's ever hugged me in a trial before, so I'm not an injured worker. And it was just beautiful.
To be clear, they had been hugged, just not at a trial.
Well, it was a workers' comp venue. So anyway, Sharon, how about you are a nurse and nurse case manager?
Absolutely. So nurses performing UR need to engage in appropriate discussions, communications, and provide pertinent education to the examiner and requesting provider. And I have to say, you know, examiners have a very difficult job. They are very passionate and well-intentioned, and I think when they are able to have a clinical nurse to consult with, it is very beneficial for their role also. If a doctor is asking for a boatload of physical therapy, call him and ask him if he would consider asking for 6 to 12 visits, whatever may be appropriate for the diagnosis, and then reevaluate the injured employee to see if it's leading to functional improvement. And on the flip side of that, if you have therapy that's helping somebody and they're progressing, and it is a few more visits than what the guideline range allows, the nurse should really have a discussion with the examiner, and the treatment should be authorized. If they're getting functional improvement from it and the doctor feels he needs a few more visits to get him back to work, it's absolutely appropriate. Both situations make sense and prevent unnecessary denials. Nurse case managers should tell the injured employee to call them whenever they have a concern about their treatment plan, provider, or after they see their provider and find out the doctor is going to be requesting authorization for treatment. So many times the doctor will tell the injured employee, I'm going to be asking for authorization for something, but it will probably take months, you know, to get it authorized. That's not true. Sometimes the UR company doesn't even have the request. So the nurse can actually pick up the phone and get the information to expedite the authorization process. Nurses doing UR need to look at every individual case fact at each request. Cookie cutter, 10-minute, or assembly line UR does not provide optimal outcomes, but it does lead to inappropriate denials and unnecessary delays in the employee's treatment plan.
So I couldn't agree more with what Sharon just said. I would add a few comments, and that is you got to get old-fashioned, and I realize that that can be difficult. I'll explain what I mean in just a moment because of time, and no one has enough time, be it any of these stakeholders. But the old-fashioned approach is sit down and meet with the critical people that you're going to be working with. So as a clinician, I want to get to know that employer. I want to know what their return to work philosophy is based on what Dr. Feinberg mentioned. It may give me an educational opportunity to reinforce why transitional work can be so effective both for the employer and for the patient in that individual's recovery. So make the time, sit down, talk to each other, get to know each other, and in the perfect world, go and visit the worksite. If you have a large referral source from a certain employer, really get to see what their employees and ultimately your patients may actually be dealing with. Because the perception the patient has may actually be somewhat different than the reality of their job duties. And then the other point that I would make, in addition to going out and meeting with people, is for those claims folks out there, be careful what you're actually deciding. If you're really making only UR decisions that have no ultimate positive impact on the ultimate recovery and the course of that case, you may be penny wise but very pound foolish. And it's hard to put a price tag on the frustration that can be created, not solely based on a denial, but based on the lack of that claim moving to appropriate and timely case closure. And that clearly is ultimately in the patient's best interest.
So admittedly, I stole this slide from Dr. Feinberg, and frankly, I'm not ashamed of it. I think it's a great slide. Words, and a fabulous word that I heard today came from my colleague Sharon Mather, boatload. What is a scientific metric for boatload, Sharon?
It's a lot.
If we're going to be fair, I have to say I got this slide from Dr. Christian.
Okay, great. Thank you, Dr. Christian. This is a great slide. You know, the graphic is self-explanatory. Words have power. I think we need to ensure that we attribute the power to them. They have the ability to reassure, show you care, build trust, certainly create the right expectation. Words can empower someone, certainly have the ability to grow relationships. Conversely, though, words also have the ability to frighten, to show a lack of interest or caring, to sow distrust, insecurity, create negative expectations, undermine someone's opinion, and instigate feelings of alienation. And in my opinion, some of the best advice that I ever got was to treat words as the valuable tool that they can be.
You know, Carlos, before you go on, I want to give an example of something. You know, I see injured workers every day, often just for an evaluation, not for treatment, serving as a QME or an AME. And I don't want to, I mean, I can't give you science here, but my gut is that so many, and of course I'm seeing pain patients, so these are usually not good outcomes that I'm seeing, but so often the communication thing we've been talking about is the primary thing. These people, when they were injured, felt no one listened to them. Whether their doctor was right or wrong, there were denials of care. I saw 3 people this morning, and it was everyone was the same story. They just feel disvalued, not respected, and I just can't emphasize enough how critical it is for us all to treat these injured workers as our friends, our family, our people. We need to help them get back to work, and it really actually saves money. It actually is good for claims to have this kind of attitude. Please go ahead.
Carlos, I'd actually like to say a little bit more about words also. You know, the physicians really have a difficult job, and so many times we don't take the time to say thank you. When you have an MPN in your medical provider network and those doctors are really trying hard to do everything right, it's important to stop and tell them what a good job they're doing. Our medical provider network person actually sent thank you cards on Doctor's Day to the doctors that treat in our MPNs, and I cannot tell you how huge that was. Doctors actually called her and said, I have never gotten a thank you in my life. I didn't even know it was Doctor's Day. It made a big deal. And sometimes, you know, we're going after the doctors to explain this or explain that, or you need to use the MTUS and you didn't do this, or we need this. You know, we have to have that information many times, but we also have to stop and make their jobs easier so that they want to take care of our injured employees. I think that's very important.
And I would add, Sharon, just the converse, and I appreciate you acknowledging how impactful that very small but important step can be to the physician. But we as physicians, especially if you may be new into this benefit system, you're trying to grow your practice, is do the same. The claims examiner has a very difficult job. They're being pulled in many directions. They're having to follow legal mandates. They have timeframes to get benefits out and UR decisions made. So when they do something as a claims examiner that really helps your patient, contact them, thank them, and I can promise you the next time you put in a UR request, that UR request is probably going to be handled in a very positive way because of that small reach out to that other stakeholder.
You know, one of the questions that we all get asked when we do seminars like this is, well, and we actually got a question already similar to this, you know, what do we do if the doctors doesn't behave, if, you know, the OD clinics we have are really not very injured worker friendly? You know, as a pain specialist, I would go absolutely nuts if I let the big picture drive me crazy. And I think you just need to focus on what you can do, and literally one injured worker at a time. If you can help one injured worker get back to work, you know, remain in their marriage, have a better life, have money to pay for their kids' education, you will be doing a wonderful thing. There are going to be lots of examples where our best efforts fail miserably, and you can't let that get you down if you want to stay sane and in this system.
Very, very, very well said, Dr. Feinberg. I do want to encourage our audience members, if you have any questions, please email them to WorkComp Central. We're happy to answer them. We've got a couple of questions that we'll be addressing here at the conclusion of our presentation. So if you have them, send them along, and we'll do our very best to answer as many as we can. You know, the solutions that we discussed today, they will work. They will make a difference. Communication, treating people with respect, to the more technical things, right? Time frames, making sure that you're following the regs, that you're doing things in the manner in which they're intended. But they're not the only solutions out there. And frankly, we really hope that everyone attending this webinar is inspired, from, you know, the claims professional to the UR nurses to attorneys and everyone in between, that you should continually ask yourself what role you can play in removing, you know, the friction that is oftentimes inherent in the work comp system to help recruit and retain high quality medical providers to treat injured workers. Now, as a closing slide here, these beautiful faces that you see, they look great. I'd love to hear your comments about how wonderful these guys look and how wonderful they did. I want to say a very special thank you to my colleague, Sharon Mather, for all the time that she spent putting the information together. Certainly, Dr. Wiesner, thank you so much for taking the time to contribute. Dr. Feinberg, I know that you're all very, very busy. So I sincerely appreciate the time that you've put into this presentation. Every person and process in the workers' comp system should have a common goal and purpose: to preserve, facilitate, and ensure the injured worker receives timely, high-quality, evidence-based care that promotes optimal functional improvement and restoration. Now, as I mentioned, we have a couple of questions that we'll go through, so I'm going to address this to our panel members as well as to Sharon Mather. And this is coming from someone in the audience. I know I'm getting ahead of this presentation, but one of the concerns in the Central Valley is the buying of local clinics by mega hospital corporation providers. Is there a strategy in place for local personal care?
I mean, I'll start off answering that. You know, there's not much you as an individual can do about that. You know, I mean, when young doctors come to me out of medical school, out of their residencies, I tell them, do not in any way try to open a private office. I mean, those days are gone. Those of us that have our own little offices, I think they're not going to be here in 10 or 20 years. I think we have to work within the system. If you're working with a big clinic or a big system, don't feel embarrassed about going to the person running that service. They want your business, and they may assume that you want them to be harsh or, you know, tough on injured workers. Just the opposite. You should really tell the clinics you work with that if they want your business, you want the injured workers to get appropriate care, you want them to get better, and that you're supportive. And in fact, if they are detecting delayed recovery factors, you need to know about that. You need to know about the injured worker who clearly is not going to do well. And because those people need to be flagged, you need to get them to the right doctors. I'm not sure how well I've answered that question, but that's my answer.
Yeah, and you know, actually, so I really believe in customized MPNs and that personal touch, and whether it is a large clinic bringing in new physicians, there should be the appropriate vetting going on with those physicians. And additionally, if there are small clinics where there is a doctor that's doing a great job, that MPN partnership means a lot, providing the education that's necessary and monitoring and seeing how they function. If they're getting a lot of denials and not sending people back to work, then there's time, it's time to have some educational sessions with that and see how they do.
And the only thing I would add, and I don't want to be a Pollyanna, I'm not clear what the scenario may be that is being driven by the question, but if you do see larger corporations buying up smaller health specialty groups, don't lose your values. If you value what is on the slide, what Carlos just shared, as best as you can within that community, find an employer, find a medical group that upholds those same values of practicing with a focus on EBM, practicing to allow you to address the entire individual from a biopsychosocial perspective as it relates to the work injury, and always doing what's right for that patient in getting them back to their highest level of function. Don't lose your values in that process.
I see a trend just starting to occur. I was approached, I don't want to mention the agency or the employer, it is a city, but I was excitedly told that they've just got a new program where they're going to basically somewhat bypass UR for their favorite doctors who actually practice evidence-based medicine. So it's a win-win for me, it's a win-win for them, it's certainly a win-win for the injured worker. And I don't mind being scrutinized, but frankly, why not scrutinize me after the fact and let me take care of this person and prove I can do it? Because I have to tell you something, it may be legally correct, but every time I have to put in an RFA and tell the injured worker, well, we'll have to deal with this next time, we'll see what they say, it's just creating a barrier.
Mm-hmm.
I've got another question, and we're just a couple of minutes out from our hour deadline. Again, thank you all so much for joining. But last question for our panelists today, with respect to communication and Dr. Feinberg's example, often the PT network itself intervenes with the denial or modification of the PT plan, even if the URO itself has approved the PTP's request. What should happen when this takes place?
I don't even know what that means. I'm not sure how to address that. I just think that, the doctor writes the physical therapy order. If it doesn't make sense, it's good to have that discussion with the doctor. If the physical therapist, if that's what we're talking about, feels that the order is incorrect or the approval is incorrect, then there needs to be that old word we used before, communication, to do the right thing to get that injured worker back to work.
It just highlights the importance, again, of the relationships, and the physical therapist, the occupational therapist, the acupuncturist, they can all play critical roles within the care of that individual. Having direct communication with the PTP, perhaps to clarify this UR example, is obviously the right thing to do.
Sharon, do you have anything to add to that?
No, I would state the same.
Excellent. Guys, thank you so much for joining us this afternoon. We really hope that the comments that we shared today were beneficial and inspire someone for the next round of conversation around this theme. I think that it's a theme that is important enough to continue going, not just in California, but throughout the country. If you have any comments or any questions that you weren't able to submit during this time frame, please feel free to send them my way. My email address is being shown on your screen, cluna@risico.com. Thank you so much. Have a wonderful afternoon.
Thank you, Carlos, Sharon, Dr. Feinberg, and Dr. Wiesner. That was great. Thank you, attendees, for joining us this afternoon. Please allow up to 3 business days to verify your attendance. At that time, we will be sending out certificates to each of you using the email addresses we have on file. If you have any colleagues that missed this webinar, or if you wanted to view this webinar again, we have recorded it and will be placed on WorkComp Central early next week. On behalf of everyone here at WorkComp Central and Risico, have a great rest of your day.